Excellent. As soon as I can get my slides, we're on. So my name is Toby Richards, and hopefully the slides will come up, guys. Excellent. It's a great pleasure to be back at the Homerton. I trained here in the last century before the recent executive was born. And we're currently sitting at the place of the old junior doctor's accommodation, so you're in my bedroom. So what am I doing here? I'm a vascular surgeon, so I'm the bloke you call when you stick all those chopsticks in the wrong pipe. But my work has been on how to optimize people prior to surgery and fitness. And the problem was about 10 years ago, was that we identified the association between anemia and poor outcomes after surgery. And it's kind of a bit logical, isn't it? If you're anemic, you feel a bit tired, you feel a bit unwell, you're more likely to have a slower recovery from surgery, have more complications, and have a worse outcome. Now, globally, the commonest cause of anemia is iron deficiency, commonly nutritional, or in high-income countries, we're talking about women's health here. We're talking about women who've got heavy periods that affect 1 in 3 women, of whom 2/3 will be iron deficient. Every other person in the world is a woman. It's the single most common disease that affects women. It was identified in 1958 as the ideal target for screening. Yet here we are, half a century later, there is a new screening program for either heavy menstrual bleeding or iron deficiency in women anywhere in the world. So, this talk is about changing preconceptions and addressing something that will be really common to your patients. And I'm going to go through it case by case. This is not one of the results of your surgery. Or it could be your daughter who's joined Kim Kardashian with vegan in February, and at university her grades are falling. And what I want to do is explain iron metabolism, because this is crucial to gut function, and you guys keep changing the way the gut functions. You have about 4,000 milligrams of iron in the body. Most of that, 2,500 milligrams, is used to make the red stuff in your blood. Blood goes round and round, and every 120 days it gets recycled as the cell membrane gets fragmented by the spleen, and you pee out the debris. Iron, Latin ferro, gets recycled. There's no natural way to get rid of iron. And iron is moved around the body by transport the iron transfer, and it's stored in the biscuit tin, the ferro tin. You have about 1,000 milligrams of iron in reserve in the ferritin, and that's enough to grow a baby, or enough for about 5 years of being on a vegan diet. So every day you literally only need 1 to 2 milligrams of iron to be absorbed from the gut, because every day you just lose a very small amount through skin or gut cell loss. Now when you break this down, if you imagine the left side is the gut, and this is an enterocyte, food goes into the stomach, which is an acid washing machine. You need a pH of less than 1.8 to dissociate the iron from the food. And then, in the duodenum, and only in the duodenum, is iron absorbed. And there are 2 pathways. There's the E passport gate, the fast and efficient one, for heme iron, for HCP1. Or there's go and join the queue with everyone else, magnesium and zinc are down there. And you have to have ferroreductase to be imported through DMT1. The difference is about tenfold. The bioavailability of liver iron is around about 30-40%, but not in the liver since 1912. Red meat, about 20%, white meat, fish, chicken, about 10%, spinach, 0.1%. So, Popeye was wrong. This is a kilo of spinach, and what I hold in my left hand is much better for you. Okay? So, telling people to eat leafy green vegetables is absolutely hopeless. Okay? It does not work. You cannot eat your way out of iron deficiency. So, there are a few salient things that have come up that I want to bring to your attention. Laboratory reference ranges are designed to calibrate a machine. They are not clinical reference ranges. If we take a group of fit and healthy people and radio-label food, iron absorption is static at a ferritin level above 50. And And so at 50 to 250, you absorb 1 to 2 milligrams of iron a day. Between 50 and below, you exponentially increase your absorption capacity. But your food, your bioavailability, won't meet that. So between 50 and 30, you will move up to about 2 to 3 milligrams of iron a day. So that's the equivalent of having a hamburger on top of a normal balanced diet. Below 30, you need 4 to 8 milligrams of iron a day. You need to be on full dose oral iron supplementation to be able to deliver that level of iron. And the WHO criteria of iron deficiency remains 15, but NICE in August this year changed the definition of iron deficiency to a ferritin less than 30. And this is relevant because we're starting to see more data come out. There's this amazing belief that you can't be iron deficient without being anemic. Well, hang on, if your car is not working, why don't you check the oil to see what is in the petrol tank? Hemoglobin is one thing, iron is another. And if you start looking at the impact of iron deficiency on red cell metabolism, for instance, MCV, once your ferritin drops below 25, you'll start seeing the MCV changing. Because after all, there's less hemoglobin in the cells, the cell gets smaller. And one of the earliest signs of iron deficiency is an MCV that slowly drops over time. Iron supplementation in the UK is ostensibly much the same. Iron sulfate, gluconate, bisgluconate, fumarate, it's all exactly the same. It's an iron bound to a salt, and the elemental component is about 65 to 70 milligrams. The rest is pure advertising. Florex, good grief. #1 selling iron supplement in the country. Utterly hopeless. Okay? It's got 15 milligrams of iron gluconate in the back of it. It costs 16 quid from Boots. If you go to Tesco's, you can buy iron gluconate 15 milligrams for £2.50. The other thing is, as you absorb your iron, when you take iron, you activate the hormone, the passport control officer, that organizes the absorption. So the more iron you take on board, the more you then block the absorption. The quota of people allowed in is done. So taking iron once a day is all you ever need to do. And actually, if patients can't tolerate that, these data from the same lab in Zurich suggest that alternate day iron is probably about the same, because you'll have a greater fractional absorption of iron. Take a 200 milligram tablet, you absorb 8 milligrams. Take another tablet 4 hours later, you'll only absorb 1 or 2. But if you wait 48 hours, you'll absorb about 8 milligrams. So, what do women complain of? Okay. Women will put up with all sorts of things. Okay, heavy periods, brain fog, etc. But the symptoms of iron deficiency, exhaustion, fatigue, the best question is 2 flights of stairs. You get short breath walking up 2 flights of stairs, you develop palpitations, chest pain, and you feel dizzy. Frequent headaches. But don't overestimate the mental impact of iron deficiency, because iron is fundamental for neurotransmitter synthesis. Brain fog, inability to think clearly, forgetfulness. And 1 in 4 women who present for an iron deficiency can be medicated for anxiety or depression. The causality is the iron deficiency. Severe symptoms of iron deficiency: eating ice, agaphagia. In the textbooks they talk about clay, it's ice in Europe. Itching and restless leg syndrome. And these symptoms, in this survey that we did through social media, 10,480 respondents, the average duration of iron deficiency is 8 years. And that is why iron deficiency is a disease. And the WHO ranks iron deficiency anemia is causing the same level of disability-adjusted life years as having diabetes. So the treatment ideally is an iron infusion in this setting. You can go on to tablets for 6 months, but in your patients, okay, if you're obese, your adipocytes secrete leptin. Leptin aggravates hepcidin because it's a pro-inflammatory cytokine. If you've got inflammation going on, you reduce your ability to transport iron, and so oral iron won't work. Post-bariatric surgery, you chop part of the stomach out, pH to dissociate the iron won't work. If you bypass the duodenum, you can't all right. So this is a huge problem in the States because people get covered by Medicare for 4 years. But 4 years later, 6 years later, 7 years later, the patients develop iron deficiency and they're not covered for an iron infusion. So time is really short, but I'll leave you with one final couple of slides. The running mice. So when I was supposed to give this talk, I could do all the science, but you can have the running mice. So what we did is we took a group of mice and we made them iron deficient. So half of them got a Kardashian diet, half of them got a normal diet. And what we showed is that if you make the mice iron deficient, their ability to exercise is significantly reduced by about half. We gave them an iron infusion, and within 3 days, their muscle function and ability to exercise returned to normal. We've looked at this, and it's to do with the ATP generation in your aerobic muscles, because after all, food plus oxygen is metabolized to energy through aerobic metabolism. That's your cytokines. Cytokines, the core ingredient, iron. So if you reduce cytochronicity, you reduce your ATP generation, which means you reduce the ability to generate energy. So I'll stop there because time is running out. But if you are iron deficient, which is a huge issue, pre-op in bariatrics, and unquestionably impacts 2/3 of all people after bariatric surgery, it's not about the anemia, it's about the iron deficiency. And that will impact mental health, it will impact physical health, and the mechanism is due to failure of ATP generation at a cellular level. Thank you very much.
Thank you very much for that great talk and overview. I'm sure we have several questions. Maybe I'm allowed to start. You know, in bariatric surgery, in many procedures, you exclude the duodenum. So what would be your suggestion for iron supplementation? Only IV, or is there a place for oral supplementation?
So I think in the acute setting, pre-op or post-op, within the first year or so, it's intravenous iron. And intravenous iron now is as safe as giving an antibiotic. Okay, disclosure, I run the biggest private intravenous iron service in London, but hey, it's run by my PhD students, okay, we're not for profit. In the acute setting, they need an iron infusion. There's no ifs and buts. Long term, as the gut readapts, you will start to see DOT1 expressed throughout the rest of the small bowel. We don't know enough about that because we know it works in mice, but we're not so sure about humans. But I think you can probably supplement Centrum Plus would be a good one. But really, you've got to talk to the patients. If they're starting to become anemic and they're suffering, iron infusion. And an iron infusion, we give 1,000 milligrams of iron, and in most people that'll sort them out for about 5 years.
With iron infusion, you have different classes of substances that you can give different amounts. Which one would you recommend?
So in Europe, we predominantly use pharyngectal monofert, which enables 1,000 milligrams of iron. In the States, they use the old-fashioned iron sucrose, and that's just due to funding issues. That's a completely separate story. But pretty much mainly that's 1,000 milligrams up to 2,000 milligrams. There's no real difference between the main products anymore.
So, if I may, in the pre-op setting, where you've got a slightly anemic patient, slightly iron deficient, I assume you're recommending iron infusion.
Yeah, I don't think I've kept away from. I ran a very large trial called Prevent about pre-operative anemia. I think in bariatrics you've got a bit of time, and so if you can do an iron infusion 1 month before, fantastic. If the ferritin is less than 30, then an iron infusion is the way forwards. If the ferritin is slightly higher, say 120, you're probably better off just doing it in recovery, because the patient's got a line in or being monitored. It's about ease and simplicity.
Ferritin itself often is also a surrogate parameter for a certain degree of liver dysfunction.
Yeah.
Do you want to comment on that?
So if you've got a low ferritin less than 30, unquestionably you're iron deficient. If the ferritin is slightly higher, it could be secondary to inflammation. Normally, outside of someone who's pretty sick in hospital, it's not so much of an issue, to be perfectly honest. If you're in hospital on an immediate month after surgery, then ferritin's not that accurate. but look at the pattern over time. So look at the ferritin, the transferrin saturations, and look at the change in MCV. So if the MCV is falling over time, then that person's probably iron deficient. But what you're getting at is, in that acute setting, you don't need to rush into it. You can probably wait and reassess.
And just to be clear, in terms of the post-op patient who is iron deficient, who's had a bypass or a sleeve gastrectomy, and there is any symptoms at all, an iron infusion is the correct way forward for it, because quite often what will happen is that someone's iron deficient, they prescribed iron, which is never going to work. It's a kind of pointless exercise. We should emphasise changing the algorithm really for this group of patients.
I think, welcome to my world. I deal with women, heavy periods, mental health, the three things people don't care about. The dogma has to change. And so I think if you've got someone who's suffering, we've got a really easy answer to it. And in your patient population, post-bariatric surgery, if you want something that works, it needs to be an iron infusion.
Just one last question. On a practical level, trying to get iron transfusion in the hospital.
It's nigh on impossible in the NHS. The rates of iron utilisation increased significantly pre-COVID. It is predominantly driven by the anaesthetists. The problem is it was an outpatient procedure and it got cut during COVID. Now the funding available to get that back on the NHS is almost non-existent. Like it or not, unfortunately, that's the state of play.
Thank you ever so much. That was a brilliant start to the meeting.